Good afternoon, everyone. Thanks for joining us. We're going to give it a couple of minutes to fill the room up here. Good afternoon again, everyone. We're just going to give it probably one more minute here to fill the room up. Thanks for joining us, everyone. We'll give it about 30 more seconds here. Okay. Good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on zeroing in on state and COPAY accumulator adjustment programs. My name is Brett Spitali. I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you'd like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to the panel after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, January 29th. I'd like to introduce our presenter today, Kollet Koulianos, our Senior Director of Payer Relations at NHF. Thank you for taking the time to join us today, Kollet, and I'll now turn things over to you.
Absolutely. Thank you so much, Brett, and good afternoon, all. I appreciate you taking time to join us on this important topic, COPAY Accumulator Adjustment Programs, which I'm sure you guys are all too familiar with at this point. So next slide, if you would, Brett. This is just an outline of what we're going to get covered today. And of course, at the end, there's going to be time for Q&A. And if you have any questions during the presentation, feel free to submit it through the chat. And if it's something I need to stop and explain, then they'll let me know that. So thank you so much, and we'll go ahead and move to the next slide. So what are COPAY Accumulator Adjustment Programs? Well, for the sake of anyone on this call who may not have gotten the official definition on this, a COPAY Accumulator Adjustment Program is really a change in how health insurance plans, it's just applied to commercial health insurance, and pharmacy benefit managers apply and account for copay assistance that they receive on behalf of a beneficiary or patient. So when a copay accumulator adjustment program is implemented on a plan, which, by the way, 60% of all commercial plan covered lives now have an accumulator adjustment program. So the number is rapidly growing. But when they do implement these programs, they no longer allow the beneficiary to continue to use manufacturer copay assistance, but they no longer allow the beneficiary to have those dollars count to the patient's deductible or out-of-pocket, also known as their cost share. Now, we all know that in our world, the hemophilia drugs have the manufacturer assistance dollars, there's an annual limit. So they'll let you use those dollars up until you meet the annual limit. And once you meet the annual limit, then for the plan will then reset the member's out-of-pocket and deductible to reflect only what the member or the beneficiary himself or herself has paid. So if you've paid nothing yet and the only thing you've used to pay towards your drugs is that copay card, then come March or April when that card runs out, then you're going to be responsible for the full deductible and out-of-pocket at that time before you can access your meds. So that's where the real issue is for our community. So if you would please go ahead, next slide. You know, one of the big problems, I mean, besides the fact that they're just there and that they're allowed, is that they also go by very inconsistent and misleading names. Express Scripts, when they rolled it out, they call it Out-of-Pocket Protection Program. Caremark, True Accumulation. United Healthcare, Coupon Adjustment Benefit Plan Protection Program. Now, most patients who've been affected will say, yeah, I mean, I think I got a notice about this, but I thought it was something good. I mean, they're calling it out-of-pocket protection. So very misleading names. They don't have it in front and center on any of the documents. It's usually buried somewhere within the plan language, so it's also very hard for patients to even know whether they have it on their plan. Next slide, please. So where does the problem really start? Well, the problem is even if it was on the front of the plan document, and even if it was more understandable, and they didn't call it these confusing names, we still have an issue in our country of people being able to understand the basic healthcare terms. It's also confusing. You pay a premium to get your insurance, but that premium doesn't count to your out of pocket that you must meet for the plan year. What does count to your out of pocket is any deductible. And by the way, you have to pay the deductible in its entirety before the plan will pay the first penny. So if you're in a high deductible health plan, your deductible could be anywhere from $1,500 all the way up to the max deductible this year, which was $7,100, I believe. We'll go through those numbers here shortly. Once you meet your deductible, then your co-pays and your co-insurance will kick in until you meet your max out of pocket. So less than 9% of the population even understands this. So forget being able to, like I said, even if they didn't call them confusing names, what does it mean when a member's accumulator is met or whether it's not met or applied? Very confusing for healthcare consumers. Next slide, please. So what are the plan limits in 2021? They go up every year. So if you're in a non-grandfathered ACA compliant plan, so that's a plan on the marketplace, small group plan, or it's a fully funded commercial plan, then in a small, fully funded commercial, then the max out of pocket this year is $8,550. The max family out of pocket is $17,100. So can you put money in a health savings account with one of these plans? No, because they're not high deductible health plans. The only time you can contribute to a health savings account is if you are in a high deductible health plan. So the high deductible health plan limits this year, a high deductible health plan that qualifies you to put money into a health savings account that's pre-tax is $7,000. So the max you'll pay for your out of pocket, that includes your deductible, is $7,000. The max you'll pay for the family is $14,000. But where the problem comes in is that you can save in your health savings account pre-tax, but the most you can save in 2021 is $3,600 for an individual or $7,200 for a family, far short of the max out of pocket. And this money in a health savings account, unlike a flex plan or a Section 125 cafeteria plan, this money is not available till it's saved. So even if you could save the max $3,600 for an individual, you're going to take so much out of every paycheck. And so you can only use what's already in your account. So this is where there's a huge problem for our community. So go ahead, please. So frankly, the dollars and cents don't add up. And the data I'm sharing is all pre-COVID. We know these numbers are definitely going to be different. They're going to get worse before we go back up and get better. But pre-COVID, the median household income in the U.S., which actually had the biggest increase in a year in 2019, is $68,703. That's median household income. Okay, so then you have your max out of pocket, which remember is $8,550 for an individual, and your max family out of pocket is $7,100 or $17,100. Now you have to also consider you have to pay your premium, and you have your house, your kids, your car, your school, clothes, food, all of this out of this family median household income. It doesn't add up. Now we know with COVID, the data tells us 49% of Americans had a decrease in income in this last calendar year. So how it's going to affect the median household income is yet to be seen, but we are certain it'll go down. So a survey done asked Americans, how would you pay for a $1,000 unexpected medical expense? And 41% said they would take the money from savings. Now this is $1,000, remember, not the $7,000 max deductible. Or finance it with a credit card, borrow from family or friends, reduce spending on other things, don't know, take out a loan. But that's for $1,000. And so when we get up to the $7,000 number, which is the max out of pocket, we know from data, the bank rate survey says that the average 2/3 of Americans don't have $500 put away for an emergency. So again, it's a catastrophe waiting to happen when these programs are implemented. If you would please, next slide. As I told you earlier, 60% of covered lives, commercially insured, already have a copay accumulator program applied. And others are in the process of still considering. Some say they're not at this point going to make any changes. There's a lot of work that needs to be done. These proliferated the market. They started in January 2017. The first self-funded plan rolled this out, and in 4 years, this is where we are. So it's a drastic change in a short amount of time. So go ahead, please. Next slide. So what else happened with COVID besides a decline income is that there's a large swing in employer-sponsored health coverage. So if we look at the data, what's the payer mix in the U.S. and why is this important? Remember, I told you these apply to commercial plans. So if you're on public insurance, Medicaid or Medicare, it's not applicable. But if you have a commercial plan, whether it's an individual or family marketplace, whether you got it through a broker, or whether it's employer-sponsored coverage, our company, our employer pays a certain amount of our premium, we pay a certain amount. So 60% of folks who have commercial insurance have employer-sponsored insurance. And of those, almost 70% are self-funded. And that's really a large chunk of the commercially insured, the biggest bucket. And those are the biggest group of people who've been rolling these accumulators out. Now, we know because of loss of income, there's been millions of jobs lost, which means folks had an option. If you lost your employer-sponsored coverage, you could either get insurance on the marketplace through a broker, or you could get COBRA. COBRA is generally priced out of most people's budget, so it would be the marketplace. And when folks are searching the marketplace, especially when there's a loss of income, they're looking for the lowest cost premium. And the problem that is inherent there is the lowest premium is going to mean the highest out of pocket. So next slide, please. In 2018, we being a group of multi-stakeholder group, formed the All Copays Count Coalition. I was one of the founding members, along with HIV, AIDS, cancer, MS, and NORD was part of the original group, and Arthritis Foundation. We now have 80-some member organizations in the All Copays Count Coalition. Our goal is to work both federally and state to get attention of this issue and try to get legislation that disallows this practice. Next slide. So all of the copay accumulator adjustment programs to date have been on the pharmacy benefit. So even if it was the health plan that rolled out the language, it was still when you got your drug at the pharmacy counter. There are a lot of people in our community that their drug is billed through the medical benefit. And up until recently, it hasn't been on the medical benefit. Now, in the fall, United Healthcare announced that they were going to roll it out in a staggered approach starting in January on their medical benefit. Although that was canceled for now, because our All Copays Count Coalition, along with the American Medical Association and many organizations out there, jumped up and down and went after United Healthcare on this issue. And so they have, for now, they've called it off. But that doesn't mean it won't come back at some point. So next slide. So I'm going to go through a scenario just so that you can kind of really get a grasp of what a copay accumulator adjustment looks like. We're going to use an example here, John Doe, and we're going to say he's in a high deductible health plan, which of all the commercially insured, the largest bucket is folks that are either on a high deductible health plan or I'm going to draw a blank right now. But it's a large chunk of folks that are on high deductible health plan, and that's really the market of people that are the most impacted. So high deductible health plan, this gentleman's on. He's got a $5,000 deductible, just for the sake of this example, and he has a max out of pocket of $5,000. Now let's assume his monthly drug cost is $20,000. And he has a manufacturer copay card that he can apply to help him with his deductible and out of pocket, and the value of that card for each year, max $15,000. So next slide. So let's look at a scenario before copay accumulators, or let's just say the plan does not have a copay accumulator adjustment on it. So how it would work is in January, the member would call, I need my clotting factor, to their pharmacy. The pharmacy would apply the manufacturer copay card to the member's order. That would be $5,000. Remember, that's his deductible and max out of pocket. The insurer would pay the balance because $20,000 is what it costs minus the $5,000. The insurer would be paying $15,000. And then after that, the member would no longer have a deductible or any out-of-pocket because it was met. And so for the rest of the year, assuming he has no other healthcare expenditures, just that clotting factor, every month when he calls to get his meds, the insurer pays the full $20,000. The manufacturer card is no longer used because they got the first $5,000 and that met the patient's out-of-pocket, and the patient had no out-of-pocket. So at the end of the year, the cost to the pharmaceutical company was $5,000, and the cost to the insurer, they're paying claims, were $235,000, and nothing was paid by the patient. Now we'll look at the next scenario. Once an accumulator adjustment program is implemented, the member would call his pharmacy in January, get his medicine, the pharmacy would apply $5,000 from the manufacturer copay card, insurer would pay the $15,000, but on the back end, that wouldn't be applied to the patient's out-of-pocket, so it would still show he had a $5,000 owed deductible. All right, February, same thing, he calls, he doesn't even realize this has happened generally. He calls, he gets his meds, they take another $5,000 off that card because remember the card has a value of $15,000 and the insurer pays another $15,000 and the patient still shows they owe $5,000. March, they take the last $5,000 off the card. The patient's out-of-pocket is reset to reflect only what they've paid, which at this point is nothing, so they still owe the whole $5,000. And by the way, where does accumulator come in? The term means your accumulated out-of-pocket spend. That's how insurers refer to it. So your accumulator at this point still shows you owe $5,000. You've paid nothing. So come April, when you call to order your meds, there's no longer a balance on the manufacturer card. It's used for the year. So there's nothing they can take from there. The insurer is not going to pay a penny until you pay your first or your deductible. And so once there's no more money to pull from and it's reset on the back end showing you paid nothing, you've got to come up with the whole $5,000 or you can't get your medication. And that's where obviously the problem is. If you go to the next slide, Brett. So if you compare the two scenarios, the total cost to the patient in example one, when there was no accumulator, was nothing. The total cost to the pharmaceutical company was $5,000. The total cost to the insurer was $235,000. If you look at the scenario two, once they implement the accumulator, the total cost to the patient is $5,000 because come April, he either had to pay that $5,000 or he wasn't getting his meds. So even assuming that everyone had that $5,000, which we all know is not the case, then he would have to come up with $5,000. And then the total cost to the insurer, as you see here, is $220,000. So to them, it looks like they saved $15,000 implementing these programs. So it's a moneymaker for the insurer or the pharmacy benefit manager. And here they've collected that $5,000 how many times? 4 times. They collected it in January, February, March, and then again in April from the member, if the member could even afford it. So, you know, it's not just double dipping, it's triple and quadruple and even more, depending on what the deductible is. Next slide, please. So what has NHF been doing? Besides taking the full lead on this, identifying it when it first was implemented, we were the first to identify it, but we've started with just trying to understand what are these? Are they legal? You know, it took months to even find one other organization, whether it was pharmaceutical or advocacy organizations, legal firms, business groups on health, media. No one had heard of it, so nobody would touch it. It was several months in that we started getting calls back from some of the folks we reached out to saying, okay, tell us about that thing you mentioned. And so once we had a grasp of what this was that was being deployed, we immediately knew that there was unintended consequences that would occur for patients that are in our community. Because our drugs that they rely on are life and death. I mean, these are high cost, but they're high value. So we started developing a point-counterpoint list. You know, as we heard from the people who are proponents of copay accumulators for why they should have them, we documented it, and then we started developing our challenges to those points. We developed a one-pager, and the list goes on here. I'm going to go through these things. So next slide, please. So our point-counterpoint list, these are some of the main points that have been bantered about as folks who want copay accumulators would say. By implementing these, we make better healthcare consumers. because patients who don't have to pay anything out of pocket, they don't care how much the drug costs. They'll go for the name brand instead of the generic. They don't price check for if you need an MRI or some other therapy or procedure. You don't go out and look for where's the cheapest option because you're not paying anything. And they really drive home the point that this drives patients to name brand instead of generic. Well, we don't have generics in our community. In fact, most people that are targeted by these, because these really only affect specialty drugs, there are no generics for. In fact, the number is 87% of the drugs targeted do not have a generic. But our community certainly doesn't have a generic. So again, and so we developed our counterpoints here. Then they're saying, well, hey, listen, if you can't afford to pay a deductible that high, then choose a health plan that's right for you. Instead of getting a high deductible health plan, get a PPO or an EPO that has a lower out of pocket. Well, the problem is a lot of the self-funded insurance companies, and at 2 years ago, 39% of all self-funded employer groups only offered high deductible health plans. So there wasn't even an option for people. And then those that did have an option, the premium delta was so much different and they didn't understand this was going to happen. So they choose the lower premium, which is going to mean higher out of pockets. As I said, they drive patient to higher cost drugs instead of generic. Go ahead, next slide. They also claim that the rule IRS Q49 interpretation says that the individual must pay the cost of the drug up to the deductible or max out of pocket. And they were referring to this with regards to HSA rules. If you're going to put money in a health savings account, you have to be the one that pays. But what if a grandparent or a parent pays that? Or if the deductible or max out of pocket was met on other medical services, right? You can't assume just because a member is getting this copay card that they're not going to have out of pocket expenses. Because what if before their first prescription goes in, they go to the ER or have some other medical expenses? They will be responsible for those. They have, most insurers up until this last year said that they would accept assistance from a third-party nonprofit that does some sort of needs-based assessment in order to give out the assistance. However, we've seen several plans over the last 6 months that have language that specifically says all assistance. And they'll even specifically call out any assistance, including third-party nonprofits or manufacturer copay assistance. Another point they make is the ACA requires plans on the exchange to implement a copay accumulator adjustment program, and it's because they say it's the IRS rule. That's voluntary, not a rule. We had the head of CMS, CSIO, give us that information. It is not mandatory. And then they said it counteracts the current administration's effort to reduce drug pricing. The fact of the matter is we don't have generics. It doesn't drive patients to higher cost drugs. The way that health plans can develop strategies, and they do through their utilization management efforts, they'll say you have to get a prior authorization, or you can only get the drugs that are on our preferred drug list, or you'll have a higher out-of-pocket exposure if you don't. They put those in place already. So a patient isn't going to use the coupon unless he's already approved for that drug. And there's coupons available for every product on the market. So it simply does not, it's not true, the statements. Next slide. We developed a position on copay accumulator adjustment programs, NHF did, and it's available on our ccschemo.com website. You get the link on our NHF website on the front page. And so I encourage you to take a look at some of these resources, but in specific, our position on these and what the unintended consequence risk is to not only the patient, but the employer or the health plan. Next slide. And then we've been engaged on a national level, meeting with CMS and CSIO to get legislation passed to prevent copay accumulator adjustment programs. We had a short-lived success in 2019. CMS CSIO agreed with our position, and they put language in the national benefit and payment parameters that said no copay accumulator adjustment programs for on any drugs if there's no generic. That was short-lived. It was implemented in April, and it was walked back in August because the folks that are proponents for these, The lobbying groups behind those are a lot bigger and more powerful, and they got the attention of the administration, and they said, this goes against the whole drug price strategy you guys are going for. And then when we went back and continued to try to fight that for the 2021 rule, and unfortunately, the 2021 rule said a plan can put accumulator adjustment program on if they want to. So we still have work to do in that front, and that's what we've been doing. If you would, next slide. After they issued the 2021 rule, we had 72 bipartisan members of the House of Representatives to call on U.S. Department of Health and Human Services Secretary Alex Azar to drop the anti-patient insurance rules that were part of that ruling. And on next slide. And there was a bill, HR 7647, that was a bipartisan bill introduced that said, let's go back to the original language of the NBPP 2020 that says no accumulators if there's no generic, until at least a period of time after this pandemic ends. So while it's not the perfect rule, we're definitely supportive of that from the sense that as long as we get time to get to the new administration, then we would support that language. I mean, it does have to be reintroduced because it didn't go through. It was introduced in the fall. It would have to be reintroduced now. This is efforts that we're working on as All Copays Count Coalition and through NHF. Go ahead. Next slide. And then on a state level, we've been invited to, as states have been working on anti-accumulator legislation, we've been invited in to do training with the other advocacy groups so that they were prepared to understand really what these are. And then we testified in several of the states that have passed anti-accumulator language and additional states that have yet to pass the language. Illinois, Virginia, West Virginia, and Puerto Rico have the most encompassing language. This example here that you see, a health care plan shall apply any third-party payments, financial assistance discounts, vouchers, or any reduction in out-of-pocket expenses made by or on behalf of the insured toward a covered individual's deductible, out-of-pocket, or copay. So the best of the best language that's out there is this example comes from Illinois' bill. Then we have, go ahead, the next slide, in Arizona. So far there are 6 states that, if you count Puerto Rico, that have anti-accumulator language. Arizona's language is very, very much just like the NBPP 2020. It said no copay accumulator adjustment programs if there's no generic. And then next slide. And then Georgia says the same thing, except they go as far as to say, but a health plan doesn't even have to accept copay assistance. So in order of the language, the most preferred would be the first, and then in order of how we have them listed here. So next slide, please. So as you look here at this list, these are states right now that we're continuing to work with. So very busy working with legislators from each of those states to get bills introduced in those states. Some of them already have bill numbers assigned. Others are still in process. But we're extremely busy. We're working with the state chapters, as I'm sure many of you on the call worked with you in your states. And we're speaking with legislators. We're trying to get folks to sponsor these bills. Now, the good news is that the legislation is going to impact folks in those states that are on the marketplace or on a commercial plan. They aren't going to be able to regulate a self-funded plan. Those are governed differently. But with COVID, if there's any positive that came out, is that more people moved off of the self-funded plans and onto the marketplace, which is why we've doubled down our efforts in those states. But the best thing would be to get new federal legislation to eliminate this across all plans. Next slide. And then we took, what are the proponents saying? They're saying that it's not fair for John Doe to get a coupon that helps him meet his out-of-pocket when Jim Doe and George Doe sit in the cubicles down from him don't get any assistance because they don't have a chronic disease. And they said that they wouldn't find this fair. So we hired Public Opinion Strategies to field a survey for us that was launched to American voters ages 18 and over. And we said, ask the questions. And what was very good was that 86% of the respondents across party lines said that they thought the government should intervene and not allow these practices to happen. And so, and of the respondents, because this just went out to the general public, they're 18 older registered voters, of the respondents, you have to remember, a little less than 30% actually had a chronic disease. And that could have been any chronic disease. It could have been acne or asthma. They didn't identify what it was, just you have a chronic condition. So the rest of them didn't. And yet a vast majority felt like the government should intervene, and that if they didn't, this would be very detrimental for patients. So that challenges the Jim and John Doe or George Doe scenario. Next slide. And these are just some of the findings. Most important healthcare problem by those that answered is the cost of healthcare, and that it was very clear that lowering premium costs can't be resolved by hiring deductibles and out-of-pocket expenses. More than 8 in 10 voters with private commercial coverage report having an annual deductible on their health plan, and more than a third of the voters with private coverage said that their health plan had a high deductible. So a quarter to a third of the voters said that they or someone in their household had not been able to afford their out-of-pocket costs in this past year. And voters overwhelmingly believe the government should require that the companies count those dollars. Next slide. Substantial majorities believe that the government, if they don't count it, that there's going to be severe consequences for patients with chronic conditions. And a quarter of the voters said that they would not be able to afford prescription medications if they had a chronic condition in today with what they make today. Next slide. Sorry, this was repeated. Next slide. I think it'll be, sorry, next slide. And so just here's a breakdown, and this shows by those who said yes and no to the government intervening. Next slide. And then you can see it by, sorry, my dog is biting my fingers, and I'm trying to act like he's not in the room, but it hurts. So this is by parties. So Republicans, 83% said if you said yes, and of the independents and Democrats, you see it was 83% on independents, 91% on Democrats, slightly higher, but across party lines, it was, we had over 80% of folks who said yes. Next slide. So what else are we doing? So we're in process of finishing the survey. The next phase of the survey is to launch it with the patient groups. We have a multi-chronic disease group of folks that are sending it out, folks that are on the steering committee of the All COPAYs Count Coalition. And so we've sent a link out to our community, our office. You would have gotten an email from NHF. We've also had chapters offer to send the link out to their community. And so please, in the chat, if you would share the link or know anybody who's been affected that would take this survey, please identify yourself. This is very important that we get your opinions. And then we are developing an RFP to conduct an actuarial study, hire somebody like PricewaterhouseCoopers or Milliman to actually do a deep dive of the data and challenge that by not having a copay accumulator adjustment program is not costing the health plan more. In fact, it's profiting the health plans to put them on. And so we need to challenge their arguments, and we need to have actual data to do it. So that's where we're at. Next slide. I believe that's the last slide. Nope. Yeah, so I do want to thank you. You can contact us here at hemophilia.org, and you see the handy information. If you have my email, feel free to reach out. But the most important thing is we have to get data, and we have to share this data with the state legislators and the federal government. There's hope. We have a new administration that tends to be more responsive to folks that are in need, and so hopefully we'll get some traction in this coming year. And so I will open it up for questions or comments.
Great. Thanks so much, Kollet. We appreciate it. We do have some questions that have come in. Before we do that, I'm going to launch a demographic poll. If you don't mind, while we're answering questions, take the poll real quick. We would much appreciate it. It'll be up there for a little while here. First question comes in. How do you find out if your health plan has a copay accumulator adjustment?
Which of the following describes you? Is it the first one?
No. I'm sorry, Kollet. That's the that's just the poll that we're
Oh, okay.
asking here. The question was, how do you find out if your healthcare plan has a copay accumulator adjuster?
Okay, well, the poll question on the screen is different than that. That's why
Yeah, don't pay
okay,
attention.
don't pay attention to that. I'm
Yeah.
sorry. Okay.
No, it's okay. It's okay. So I'll ask the question again. How do you find out if your health plan has a copay accumulator adjuster?
All right. Oh, you're asking me? I'm sorry. This is the
Yes.
question.
Yep. Yeah, that's
I'm
one of the
so
questions
sorry.
that came in.
Yeah,
It's
yeah.
okay.
So again, can be very difficult to find because of the clever names that they use. But my recommendation is if to get a hold of an electronic copy of the plan language if you can, and do a search and look for words like copay, out of pocket, cost share. I mean, search by the keywords that it would likely be affiliated with. We're always happy to help look. I know when I helped several folks across the country who were making determinations on their plans, as you looked at the deck sheet that showed like what's covered in each, generally by the prescription or specialty drug section, or at the very top, it would say, you know, member only applies to what member pays out of pocket. That's a language that you'll see. So it's not explicitly clear generally, although some are getting more clear, but that's kind of the recommendation.
Great. And then the next question comes in. What is NHF, if anything, doing to standardize some of the language? And I think that's referring to what you just spoken about with the clever language that's being wrapped around this.
Well, I mean, we are, you know, when we met with CMS CIO on multiple occasions, that is part of the ask. I mean, besides getting legislation to stop it, but is how do patients even find this? How do they find it when they don't know the basic healthcare terms, let alone how do they find it with these names? And that it should be definitely more identifiable and clear. And so there are some states that are moving in that direction. But again, this is, I mean, this is in process work. We're trying.
Great. Great.
The problem
Next
too is
question.
like, it's a conundrum for me because if you push for that, as let's say you're on the marketplace and let's say you have 5 choices of plans and one of the plans or 2 of the plans do not have accumulators, but the others do. And it's real clear. All the sickest of sick are going to choose the plans that don't, and it'll bankrupt those plans or they'll end up going out of the marketplace. So it's a tightrope on how far you push that too.
Sure. Great. Next question that comes in is, how is NHF working with the chapters at the local level on this?
Well, I mean, I would say, you know, again, I don't know all the chapters that are on. I don't see the attendees at the moment, but I'm working with many of the chapters doing presentations to their communities, to their state, and several to come. I think at 9 last week reached out. I'm meeting, chapters are putting together meetings with legislators to try to get somebody to sponsor a bill in their state, and they have me on those calls. And we're sharing our resources with them and happy to have any chapter willing to send that link out. It closes January 31st. It's critical to get this data, but I also know there's a lot of surveys going on and a lot of things you're doing locally. So, you know, if you're interested, please let us know.
Great. Question that came through the chat, Colette. Is there a letter template that we can use to send to our legislators, encouraging them to support our position?
Sure. I mean, I've drafted things for people to talk to their legislators. I don't have an official template out there, but I'm happy to do that and make it available. So we can put it in the coffee chat on the chapter. I can have Michael help post that to the chapter EDs.
Great. Another question that came in, Colette. Do you have a one-sheeter that you can share with common language for copay and accumulators?
We actually am in our toolkit, which Marla, my colleague, makes sure stays up to date. We have language in there that identifies, it's like a glossary of all these terms. I don't have a specific document pulled together to like words to search for. I'm certainly happy to do it and also share that out. But I would take a look at that, our toolkit, which is available on our website.
Wonderful. And can you give the website again, Colette? I'm sorry.
NHF's website.
I'm sorry,
Yeah.
this is
The other website is ccsehemo.com, but you can catch the link for that on our homepage of our website. I believe it's at the top of it's a new website and it's wonderful. Sorry.
No,
But,
it is right across the top there.
yep, yep.
Yeah. Question that came in through the Q&A.
Mhm.
How does a copay accumulator differ from a copay maximizer?
Well, I purposely stayed away from that because it's ever more confusing. But in a nutshell, the copay accumulator adjustment program, patient uses the manufacturer card until it runs out. Usually in our community, because the drugs are so expensive, they'll run out by March, April. Then there's that cliff. You either pay or you don't get your drug. All right. Nothing counts to your out of pocket until you pay yourself. A maximizer is the same, doesn't count to your out of pocket unless you pay yourself, but with a maximizer, they spread those payments throughout the year. So if the example I gave, John Doe, who had a $5,000 deductible, and the only thing he needed all year was his clotting factor, then a maximizer would certainly be better because they would take the manufacturer's coupon, and say it's $15,000, they would divide that by 12 or $1,250 a month, and they would change the plan to say that for his hemophilia drug, instead of the normal deductible and cost share, he would have a $1,250 copay every month, and that would be taken from the manufacturer card. So they spread that out through the year. So variable copay program is another word they use. Again, those also have multiple names. And so if I had to pick one of the two, gun held to my head, I would definitely say the maximizer's better for our community. However, our community is faced with many comorbidities, and they aren't just getting their clotting factor. They have a lot of other costs and exposure. And so remember, they'll accept that coupon and it applies throughout the year. And so you'll never have that cliff. You'll get your drug, but none of that money is counting to your out of pocket. So month one, you still have to meet that deductible before the plan kicks in the first penny. And so we would just prefer that they didn't have either of these.
Great. There's a question in the chat from Fernando that I'm going to try to tackle here, so bear with me. Kollet, does the new success of the Arkansas AG versus PBM lobby at the Supreme Court that providers state level protection and does not infringe on ERISA law is a good sign for the other states?
I mean, that's potential. I mean, ERISA is what governs the self-funded plans. So like I said, the state legislation, if you have an anti-accumulator bill, it does not, they can't dictate what self-funded plans have on their plan language. They don't have to cover the essential health benefits. ERISA has a different set of rules, governed differently. Now, the NBPP that we were able to get in our favor for that short period of time, it said no plans, including ERISA plans, could have a copay accumulator. So obviously, that's the best that we could hope for, is to get that language reintroduced and it be applicable across all plans. But certainly having state legislation is better than no legislation, and it helps with those folks that are in marketplace plans and other commercially insured.
Great. Another question that came in, Kollet. Is NHF addressing any of this at Washington Days this year?
I have a meeting with my colleague Nathan to discuss this. So I don't have an answer yet.
Great. We will keep everyone posted. It seems like that's all the questions that came in. Kollet, I'd like to thank you for taking the time to join us this afternoon. We appreciate your time and expertise. And I'd also like to thank each and every one of you for joining us. Please note that this recorded webinar will be available on Friday, January 29th at hemophilia.org under the events tab with all our other archived webinars. Thank you again for joining us. And Kollet, thanks for your time. Everyone have a great day.
Oh, so hang on. Do we have a minute still? Because the question I just saw, Debbie Whelan, is there concern if ERISA plans can't use accumulator, they would just drop coverage? Listen, this is happening already, a whole nother issue that deserves its own webinar, where self-funded plans are being, there's 5 companies right now and others popping up that are promoting that self-funded plans carve out specialty drugs or orphan drugs out of their coverage. And then they will work with the patient to get free product from the manufacturer if they're income eligible. And if so, then they collect 25% of the savings, and then the company saves 75%. However, this is riddled with so many issues. I ran a hemophilia treatment center, and while getting free product is great, It's not the same as having the ability to get it from the pharmacy. It's riddled with issues for everyone in the continuum. I mean, manufacturers, that would be a going out of business sale. They can't give away all the drug for free. There would be no motivation to bring new, better treatments to market. So obviously we have a big issue with this. Unfortunately, they've been successful in about 50% of the cases, and this trend is rising. So just like the copay accumulator adjusters, this just started in the fall, and we're hearing from several HTCs and from patients across the country that this has been happening with. So if you have any examples of that, I do encourage you to reach out. We've also reached out to some legislators to talk about the impact this would have on the public plans, because they would, no doubt the cost would shift. This is just not a good deal. So.
Great. Thanks again, Kollet. We appreciate it. And thanks everyone for joining us. Have a wonderful afternoon.
Thank you, guys.